So I think when I got this real topic, I kind of felt like Joe Biden, because I was wondering what the
40% of all products coming into the United States of America on the West Coast go through Los Angeles and what am I doing here?
Is it Long Beach?
Long Beach, thank you.
So this is kind of what I felt, is like, what am I doing here in the august presence of these fantastic speakers who are discussing on trauma, and what's a sports surgeon like me doing in this particular scenario? But I think if you look at what it is, we're all looking at giving good patient care, and ligament injuries are common occurring with tibial plateau fractures. So way back ago in this particular series that was presented in CORR almost about 20 years ago, they looked at around 40 patients. Of them, 19 had a primary repair of their ligaments, 20 had a delayed repair. And what was really important to understand is that if you don't tackle these injuries in the primary scenario, you will end up having a more poorer outcome. And this poor outcome is going to be residual instability. And this residual instability is a definite cause for poor gait, poor function, and they really don't feel good. So what exactly are we looking at? And this very good paper that was published out of the HSS looked at the MR analysis of about 103 patients. 99% of them had some form of soft tissue injury. And the injury that we're going to be discussing today is going to be the injury to the PCL and the posterolateral corner. So we're going to be talking about injuries to the lateral meniscus and the capsular separation, which are present in over 75% of all operative tibial plateau fractures. The lateral collateral ligament is injured in almost about 30 to 50% of all these tibial plateau fractures. The PCL is injured in about 10 to 45% in varying forms of severity. And the posterolateral corner is again injured somewhere between 15 to 55%. So though the posterior cruciate and the lateral complex is injured in less than 50%, still it forms a very important look. Now let's find out as to what exactly are we going to look at in these particular treatable problems, because these are the injuries that we wish to treat. Because any form of complete tear.
Sachin.
Yes.
Sorry.
Please.
I cannot see your screen. I see only the text. It doesn't move. I'm sorry. And
you can't see my screen, is it?
Yeah, I saw it, but it's just the tibial plateau fracture with PCL and PLC injury. It doesn't move.
The slides aren't advancing, Sachin.
Okay, sorry. I'll just restart again, please.
Yeah.
Is this a bit visible now or still? Hang on for a moment. Sorry about this. Okay, is the screen seen now or still not seen?
Yes, sir.
Yeah, that's better.
Thanks. Yeah. So as I was discussing, I mean, if you look at this paper that was published, in about 2005, the important injuries that we need to address are essentially going to be injuries of the PLC and the PCL. And the important injuries that we need to look at, which require primary surgical treatment, are going to be injuries which involve complete tears or complete capsular separations of the structures of the PCL and the PLC. If we break these down into further classification as per the Schatzker classification, what we have now is that the Schatzker type 2 were more common in their series. And if we look at the treatable problems that need to be fixed, the lateral meniscus tear and the capsular separations, well, they're more commonly seen with your Schatzker 1, 2, 4, 5, and 6. The complete lateral collateral ligament tear is more commonly seen with the Schatzker 4. The PCL footprint avulsions and the PCL complete tears, were more common with the Schatzker 1 and the Schatzker 4 in their particular CD. So whenever you see a Schatzker 4, I think it's important to proactively look for a complete tear of the PCL, which becomes very important. And the footprint avulsion, which is a soft tissue injury, would be seen more commonly in the Schatzker type 1. And lastly, when we look at the popliteofibular ligament and the posterolateral corner, it's almost all these Schatzker classifications patterns except the type 3 are the ones wherein we may get these issues. So what exactly does this tell us? This
Your
tells us
slide
that...
not advanced again. Sorry.
Oh, really?
Yeah.
Oh, God.
It's just the same one.
Oh, gosh. Okay. Oh, God. Completely sorry for this. I really don't know what's happening here. Let me just... Why is this happening?
Fine now.
Yeah. I'll just advance through this slide because we discussed this particular one. Complete apologies. I really don't know why this is happening right now, but
Work now. Yeah, it's okay now.
yeah. Okay, so we've gone away from the Schatzker classification to now the 3-column classification. And if we look at the 3-column classification, what is important to understand is that the third column, which is the posterior column, is the one that will get injured. And when you see any sort of injury in this area, this is the one that needs to be looked out for injuries to the posterolateral corner or the PCL. What is important to understand is that now this area of this zonal area, which is in the posterolateral area, which comprises of the fibula, which is the so-called posterolateral column, is the one that really does get injured in a lot of injuries, which are commonly seen in our clinical practice. And this, if you see any injury to this area, I think it should arouse suspicion that something wrong is happening here, and this needs to be fixed and get sorted out. What is important to understand is that when you lose the posterolateral rim of the tibia, then your meniscus becomes unstable. If your meniscus becomes unstable, then your ACL is at a higher risk to rupture. And that's the reason why many of these problems would occur when you get a combined lateral meniscus injury along with instability to the ACL as well. And this leads to further issues. So this is the area that we're really talking about, which causes problems. The fibula, again, is a very important structure because it gives origin to very important structures. You have the biceps femoris, you have the FCL, you have the popliteofibular ligament, and the area which corresponds to the head of the fibula will have attachments that look at the attachments of the popliteofibular ligament and the popliteus as well. So the structures which form the so-called FCL popliteus complex are really located in this posterolateral zone area per se, and the functions of the lateral collateral ligament are to provide varus restraint and external restraint at low flexion angles. You have the popliteus muscle, which is going to provide you external restraint in high flexion angles, and you have the popliteofibular ligament, which is going to provide you secondary external rotational restraint in high flexion angles. In addition to this, you have the biceps femoris, which is the strongest external rotator of the knee. So it is going to provide you restraint against internal rotation at the level of the knee joint. And all these three structures are important when we look and deal with injuries in this particular area. So what happens when this area is injured? Not only do you get lateral opening, but you also get abnormal rotational instability. And this rotational instability, if it is not treated, may lead to problems and may lead to issues with the patients having good functional outcomes. So again, the insertion points for the FCL, which is on the anterior and distal part of the fibula, and again, near the lateral femoral condyle, at the level of the lateral epicondyle, you have the popliteus, which inserts and continues into a musculotendinous junction. You have the popliteofibular ligament, which will attach posterior and proximal to the tip of the fibula. And you have the biceps femoris, which attaches at the tip of your fibular styloid. And whenever you have an injury in this so-called posterolateral or posterior zone, which is present on your 3-column concept, you have an injury to these structures that has to be picked up very efficiently and elegantly and has to be tackled at the same stage. The fibula, again, we tend to dismiss this so-called arcuate sign. One example here of a patient having injury to his medial tibial condyle and showing an arcuate fracture as well. If you leave this or if you dismiss this particular injury, then you're more likely to have a poorer outcome in the form of residual laxity. Arcuate fractures, of course, need to be fixed primarily. And this is one such example. What you see is the arcuate fracture to the right of your screen. The femur is to the left. And then this is being fixed with the help of a stainless steel cerclage wire loop, thereby restoring the tension on the biceps femoris and the other insertion structures. A variation of this arcuate may be a peel-off injury, and that's why they need to expose the lateral aspect of the tibia properly. If you can get sometimes a peel-off type of an injury, wherein the whole insertion on the fibula is peeled off along with the meniscotibial component, and again this needs to be fixed with the help of a couple of strong sutures which are placed in a pull-out manner. What is again important here is to diagnose your posterolateral corner instability, and of course inspection may give way the clinical scenario. You can see that there's presence of bruising which extends more posterior, but however this is not pathognomic in the situation when there is a concomitant tibial plateau fracture. Clinical laxity is important, and whenever you have abnormal laxity with abnormal opening on the lateral side as well as abnormal rotatory instability, it should alert you to the possibility that there is a concomitant posterolateral corner injury as well. And last but not the least, you want to perform a stress X-ray intraoperatively, and whenever you have more than 3 millimeters of opening, when you do a side-to-side comparison, that should alert you to the possibility of having an FCL or a complete posterolateral corner tear. On the other hand, a PCL injury, whenever there is a positive step-off sign, it's pretty easy to pick this up on inspection. You can do your clinical laxity by doing a posterior drawer test with the knee flexed to 90. The PCL is graded on the basis of your step-off as a grade 1, 2, and 3. Anything that is more than 8 millimeters side-to-side difference is something that is important and that needs to be treated. And last but not the least, whenever you're looking at tibial plateau fractures which show a posterior eminence fracture, just get a stress X-ray done. And if there is a posterior sag, which is more than 4 millimeters, it constitutes an important PCL injury. And if it is more than 8, then it has to be a treatable PCL injury that one needs to look into. PCL avulsions, which are in association with a tibial plateau fracture, may be first treated by any of the methods that were discussed in the previous talks by performing an osteosynthesis. And then if it is a fracture pattern which is not included within the hemicondyles, then one may do a small modified Bade type of an approach to go ahead and fix it. If it is a part and parcel of the whole tibial plateau injury, as which was demonstrated in the previous talks, then it can be tackled through the same approach itself. We look at this case example of this 35-year-old lady with a BMI of 28. She had a road traffic accident about 7 days ago, presented with these kind of X-rays to her local physician, was referred for a second opinion. Of course, you can see that there is a fibula fracture which is lower down, but the surgeon failed to notice the presence of a rim fracture and an injury to the upper end of the tibial plateau, and she was definitely not improving. So we went ahead and got some good imaging done for her, and that's what it shows. It shows a split depression type of a fracture of her tibial plateau. And when you do an MR on these injuries, what you can appreciate is that in addition to the bone injury, which is ever so present, there is a complete tearing off of the entire posterolateral complex, which otherwise would have got missed had she been fixed only surgically, or had she been treated non-surgically completely. So she was counseled and offered for surgery. And after she was had, an arthroscopy was performed. One can see an intact medial compartment, presence of a hemarthrosis. The ACL is intact, so is the PCL. And on the lateral side, there is increased opening up of the lateral compartment. The gapping is more than 8 to 10 millimeters, and there is the presence of the fracture line and a peripheral rim fracture with depression of the lateral tibial plateau. At this instance, it was decided upon as per the preoperative clinical plan to do a combined osteosynthesis along with a repair stroke reconstruction of the posterolateral side. My normal incision for doing an isolated posterolateral reconstruction would be a straight incision that is centered distally between the fibular head and the girdis and proximally at the level of the lateral epicondyle. But since additional tibial osteosynthesis had to be performed, the incision was modified to a somewhat of a lazy hockey stick type of an incision. Going ahead, after exposure, the first thing that you want to do is to expose and dissect the common peroneal nerve. You want to release some fibers of the leading edge of the peroneus muscle, because there may be some scarring in the area of the nerve, and you don't want to get a late common peroneal nerve palsy. And then the 3 windows are made first to expose the fibula, to drill a tunnel in the fibula, and of course, then we go ahead and expose down to layer 3. So the first step is to start repairing the meniscus attachments, elevate the surface of the meniscus, put in suture anchors, put in your take sutures through the meniscus. And the order of repair on the lateral side is to first do the meniscus, then the capsule, then come to the tibia, then femoral attachments, and lastly, the fibular attachments have to be done. The important thing is repair alone will not be useful on the lateral side, and repair with reconstruction is the preferred norm, especially when you're dealing with a primary posterolateral corner injury. So we drilled 2 sockets on the femoral condyle for corresponding to the insertion points of the popliteus as well as the fibular collateral ligament. And this is the surgical procedure at the end, wherein the lateral side has been fixed with a raft plate and a posterolateral corner reconstruction has been performed. A semitendinosus graft is first tunneled into the FCL femoral insertion. It is then taken down distally and passed through an oblique tunnel made in the fibula. This is now tensioned at about 30 degrees of knee flexion, thereby tightening the FCL, and an interference screw is passed. And then the free limb is then tunneled underneath the tendon of the FCL and tensioned at 60 degrees to provide the popliteus tendon to be reconstructed. So you do a primary repair, and then you go ahead and perform a primary PLC reconstruction at the same time as well, which will help sort out your problems on the lateral side. And this is exactly what we've done. What I'm pointing it out now is the graft that forms the FCL, then passage through the fibula, and then the popliteus at the end, and then the whole soft tissues are then repaired back to its originality. This is how it looks at the end of the procedure. These are our post-op X-rays, and what one can demonstrate here is the screws for the FCL, the screws for the fibular FCL, and the screw for the popliteus, which tell us that the whole posterolateral corner has been restored and the rim fracture and the depression has been elevated, and she's had a complete osseous plus ligamentation stabilization. When these come late, what do we do? I think when you look at late presentations of instability following tibial plateau fractures, you have to first treat the bone. So any form of coronal or sagittal plane malalignment has to be treated first, followed by ligaments, then menisci, and then cartilage. Here is one such example of a patient who had a bicondylar fracture. He was treated elsewhere with bicondylar plating, a posteromedial and an anterolateral plate. He continued to complain of pain and instability. He subsequently had removal of implants, and what these were his CT images, which show good constitution of the fracture, but he had persistent posterolateral corner as well as PCL laxity, and then was then treated with a subsequent arthroscopic PCL, ACL reconstruction, and a posterolateral corner reconstruction. Another example of a patient who had a fracture to his upper tibial plateau in this particular form was treated elsewhere with a surgeon who felt that he was doing the right thing by just passing a couple of K wires, completely missed the PCL injury, completely missed the posterolateral corner injury. He then presented about 8 years later with persistent laxity and a limb that was now in valgus with malalignment at the articular surface as well. What you can demonstrate on the image on the right is that his monopedal stance view shows that there is persistent subluxation of the tibia posteriorly, and these are his CT images which demonstrate the same, in which there is malaligned joint surface. We chose to treat him with a combined osseous plus ligamentous procedure, that is his arthroscopy, showing wear now on the undersurface of the patella. I just wish he had surgery and everything was tackled at the same stage. Poor gentleman now has to deal with chondral changes as well. His trochlea also shows grade 2 changes. What he also has got is an MCL laxity with gross opening of the medial side. As you see there, his medial side is completely open. So his MCL is also deficient only if the injury had been recognized on day 1. He has no ACL, he has no PCL as well. And when you look at his lateral tibial plateau, there are grade 3 changes. All of this in a gentleman who is just about 34 years old and has to undergo and has to do good physical work. So these type of injuries do pose a challenge. You need to start restoring them. Only if you were able to sort of deal them acutely, no one would have had to deal with such kind of problems as they present at a later date. He was treated with a single stage lateral open wedge distal femoral osteotomy with bone grafting and a concomitant PCL and MCL reconstruction using autograft. I used the peroneus longus in a 3-strand form for his PCL, and he uses ipsilateral hamstrings for reconstructing his MCL. So I think what is important to understand is that trauma surgeons and sports surgeons can work together. I think it's no longer the bull and the ox story. And with this presentation, I think probably trauma surgeons would realize that some of the sports surgeons may not be as good as them, but probably can match their standards, maybe to some extent that they find acceptable. Thank you once again for having me over.